Okay, hello everybody, and welcome to the Akkad and Koka Report. For this next episode, I'm Michel Akkad, your co-host in San Francisco, and with me is Anish Koka in Philadelphia. And today we're going to return to the question of free market medicine. As regular listeners of the show undoubtedly know, when it comes to free market medicine, one of your co-hosts walks the walk and talks the talk, whereas the other co-host, and I won't name who it is, seems to be a little squeamish about living the principles he claims to uphold. And the problem is this: when you as a doctor decide to put all your insurance and Medicare contracts in the shredder, you then face a grim reality. All of a sudden, you become known as an out-of-network doctor with all the stigma that carries. And no matter how low you set your fees, how generous you are with the time that you spend with patients, and how excellent the quality of your care is, your patients still have to go your patients who have paid through the nose for their insurance premium must face an arcane and difficult procedure of filing a claim with their insurance in the hope of getting some reimbursement for the money that they paid dearly for the health plan. So our guest today has some good news for Anish. Vatsal Thakur is a clinical assistant professor of psychiatry at the NYU School of Medicine, as well as an op-ed contributor to Doximity and the New York Times. He is also the founder and CEO of Reimbursify, a startup in the out-of-network reimbursement space. And we are going to speak with him about his idea, his product, and how to practice free market medicine in a world of third-party payments. Vatsal, welcome to the show.
Thank you very much. It's great to be with you guys.
Great. So before we get started, before we have you tell us about your app and how that's going to convince Anish to make the jump, you wrote an editorial. I thought it was a fantastic, very clever editorial in the New York Times in 2016, and I'll put a link to it on the show notes. Can you tell us a little bit about that? And was that before you had developed your app, or did that give you the impetus for the app? Or
well, what's interesting is that we had started developing it when all of that happened. So about 2.5, 3 years ago, I had the fortune or misfortune, however you'd like to say, of having several medical events between me and my family members that really magnified many of the problems with third-party healthcare. In that, it stifled, some of our sort of choice in what kind of services we wanted, and the ability to get those services. And many of the complexities that we faced were kind of just random and didn't seem to have any rational thought behind them. For example, one of the situations that I wrote about was my daughter seeing an orthopedist, and then we got a bill for a 15-minute appointment for $1,100 something. And when I looked up the billing code for that, it was sort of one of these 90-day codes. So all services that we would have needed for her for the next 3 months were bundled into that one code. But with our insurance plan, most of that was borne by us. So it would have been nice to be able to choose: do we want to pay for just this one visit, or do we want to pay for one fee for the next 3 months? Because it turned out she didn't need to go back to that doctor. And then there were several other incidents that I wrote about in just the fact that it's very hard to direct your own care when, even though we're paying tens of thousands of dollars for insurance, we're sort of out of the loop. We're not at the center of the decision making in terms of where to get the services and what kind of services we want to get. And then I guess all of this culminated with what I also wrote about in that article was I had a back injury and some back problems that year, and was ordered to get an MRI, which ended up getting denied by my insurance company. And so I called up the insurance company, and I actually complained that, I'm a physician and I'm sit all day in a chair, and it's difficult for me to sit and see patients all day. And the person on the other end of the line said, well, the only way to get this MRI approved is to do a peer-to-peer MD to MD review. Would you like to do the review? And so here I was interesting dilemma to be faced with. Just hours before my MRI, I was given the opportunity as a psychiatrist to do my own pre-authorization peer-to-peer review to get an MRI approved for my own back problems. And that's when I thought, this is so much of a farce that that day I decided I need to write about this topic, because it was just, it just blew my mind.
Right. And the observation, of course, that as doctors, we have some familiarity with the system, and it's easier for us to navigate things like that when we are, ourselves patients. But when patients have to face, if patients have to face that kind of complexity, there's no way they could survive if they were to do it.
Right. There was, I had, on the one hand, I felt, a special privilege by doing that. Although on the other hand, I felt, awfully guilty, because, no one else, one out of 300 people might have been able to do that in my shoes. It was definitely a privilege granted to me in that unique situation.
Okay. All right. So tell us a little bit about your little app here that's going to, bridge the gap, because I think, I was being facetious, but I think it's, there are many hurdles that, keep doctors from making the jump if they wish to make the jump away from third-party based medicine. And that is certainly one of them. The fact that they are out of networks, that there's a lot of complexity and difficulty for patients to get reimbursed if the patients wish to see them. So go ahead.
Yeah. So in my own personal practice, I've been out of network since 2007. So Anish, I'm happy to share any tips for that transition if you like. And so in those years of private practice, I realized, life got better for me because of the decreased administrative headache. But life got a little more complicated for my patients who wanted to get reimbursed for those services as out-of-network services. And early on in my practice, people would come to me and ask me questions about how to get their claims filed. And I remember clearly one patient came to me with a stack of bills that were from my office and a claim form, and he just was desperate for help. And so I said, okay, well, I hadn't ever really thought about that part of the process, but starting around that day, I decided to look into it, and I figured, how hard could it be? And realized, well, it is kind of complicated, and I had to do a lot of research and figure out certain things. I actually bought a textbook on medical claim filing so that I'd know what I'm doing, and realized that, okay, once you cut through a lot of the what seems to be complexity about the situation, it's really a simple transaction. I mean, there's some data elements that people need to collect the right data elements and submit them in a right format, and the insurance company sees that, recognizes it, and should process a transaction. And so what we did over the last 2 years is I partnered up with a few people, and we all of us love this idea of empowering the patient and at the same time helping practitioners who function outside of the insurance networks. And we designed and architected and researched and beta tested this mobile app, which lets anyone in the country who sees any outpatient specialist with any private insurance plan basically download the app and file a claim, usually with the first one within a minute or two, and then repeat claims within 30 seconds or less.
Wow, that's amazing.
That's reimbursed by.
Does that mean that the claim, I mean, the various insurers, I mean, you're connected to all the various insurers? Or is there some kind of central processing place that will take the claim after that?
So we've built our system to basically accept any private insurance. Okay. And let's say there's a new private insurance, some small insurance company pops up. Then the first time we see that claim, we will integrate that into our system. And so there's a proprietary process which we've built that will manage, depending on which insurer it's going to, how and where that claim gets routed and submitted.
Okay.
So to the user, it's seamless. And on the back end, we built a system that sorts and properly submits those claims.
But you didn't have to get the agreement of all the insurance companies individually to sort of provide you with you just used whatever, or it's a secret and proprietary? I mean,
that's a question we get. That's a question we get. One way to look at it is claims that come to an insurance company are like big, water mains. There's just tons of water tons of claims coming through, and they have different channels to come through. So we've been able to find certain channels to get our claims to go in.
Okay. Fair enough. And do the doctors need to know what does the doctor have to do to help the patient? So presumably it's the patients who have the app, right? It's not the doctors.
Correct. So
okay.
I assume, Michelle, when patients see you, they're paying you directly, as I've learned about your practice.
Right.
And you probably give them a super bill or a detailed receipt.
Right, exactly.
That might have codes, the appropriate codes on them.
Mm-hmm.
And given that situation, that's all that your patient would need, the data that's on that receipt and a download of the app and the private insurance plan, obviously, that has out-of-network coverage. And that's all they would need to sit down and file that claim.
Okay.
So we've made it such that the practitioner, the doctor, doesn't really have to do anything different if they don't want to, except maybe tell their patients about it. And we provide free material to any doctor who wants to tell their patients about Reimbursify. We also do offer a pro-level subscription for certain doctors who want to offer the app to their patients at no charge. So in one situation, if you give your patient a receipt and tell them about Reimbursify, then they download it and they get their first claim for free. And then after that, they would have to pay as little as $1.50, $1.49 to file each claim. And except in the situation of our Provider Pro subscription, where for a monthly fee straight to the provider, then the patient would not have to pay anything to use the app.
Okay.
Yeah, it's a great. It sounds really great. It seems that I'm just thinking about the countless number of patients I saw that it seems to require a particularly savvy consumer who is kind of willing to go through all those steps. Have you found you're in New York City, correct, Vatsal?
Yeah, I live in the suburbs in Connecticut, but
do you find
are
most of the folks who you find using the app, the young millennial crowd that, or do you find is it all comers? I have tons of Medicare patients and stuff, and it's certainly everyone is very, very excited with this idea that they pay a monthly fee to something that somebody else kind of takes care of all the stuff, and I can barely get some folks to understand the whole copay thing, though that seems to be relatively settled that there's going to be a copay for whatnot. But it seems for certainly a lot of my patient population, it would seem a challenge for them to kind of navigate this and build it. But I mean,
already Anish is making big excuses.
Right.
Already, my patient population is different. They're not going to use the app.
Well, here, I can just walk you through it virtually. So, you have the receipt and you just look up, someone would just have to look up your name. We connect to the HHS database. We would pull your name and your NPI number and your address.
Yeah.
So they just have to punch in your name and find you, and that's it. And then the date of the appointment. And then we walk them through, okay, next, let's look for a diagnosis code. It could be called an ICD-10 code. It usually starts with a letter. We provide guidance for that first time. So hopefully they can find on the receipt what the diagnosis or ICD-10 code. punch that in. We do validate it, make sure it's a valid code. And then we look for the procedure code. So we say, it's also called a CPT code. It's usually 5 digits. And so we do walk people through. And once they enter that, that's pretty much it. Then the dollar amount for that visit. And that's pretty much the extent of any heavy lifting that they have to do. And then the beauty of it is the next time, let's say, for follow-up appointments, the diagnosis code usually doesn't change and the CPT code usually doesn't change. And so they literally just say, it was the same as the last visit, and they just enter the new date, take a picture of the new bill and submit. So it's, when someone knows what they're doing, it's literally a 15-second claim.
I see.
Right.
Okay.
Great. So how long have you been operating or up and running?
So we released the app in both app stores about 7-8 months ago.
Okay.
And so we're still pretty new. A year ago we were still beta testing for several months to make sure it's working right, making sure it's like you said, make sure to make it as simple for the user as possible, because it's like learning a new language for many people to know what some of these codes are, but we've tried to walk them through it and make it easier. And so every day, every week, we're getting more users, getting more practitioners on board. I think at last count, we have users in 33 states already. And people are using us for not just mental health visits, but chiropractors and specialists and physical therapy and you name it.
Yeah.
So it feels good.
Who's your bigger champion? Is it the private practice practitioners, or is it the patients that are? If you make your pitch, the patient will say, yes, I want this. It seems to me that the private practice doctors are going to be more happy to sort of bring it up to their patients, because they view it as one less hurdle that the patients have to go through.
Yeah, I mean,
the patients themselves may not be aware, totally aware of.
Right, it's an easy value add, right? Because here we're offering something that's going to help your patients, and in turn, it's also going to help you and your practice. And you really don't have to do anything extra or even pay anything extra, and just to make people aware of it. So we see a lot of excitement from practitioners, and then we see a lot of excitement from patients as well. The beauty, something we've loved that we've seen that we've just fallen in love with this concept is our super user. So every so often, every week or so, we have a super user, and they download the app, and then they file the last 6 or 8 months worth of claims. And, some of them, I think our record is 52 or something. So a user sat down and filed over 50 claims in 15 minutes or 20 minutes. Now just imagine trying to do that the old-fashioned way. It's something that
this is so this lives outside of. So if Michelle, so a direct primary care, just walk me through a direct primary care physician who is getting some, X number of dollars per month for a bunch of bundled services. You're saying if Michelle were to order a CAT scan for a patient, and that CAT scan was not a network, or you're saying out of network, they could use the Reimbursify app. If they're paying for some direct primary care on a monthly basis, is that how does that work? So would Michelle still generate a an established follow-up code, and then the patient would try to get that reimbursed from the insurance company? Is that essentially how it?
No, actually.
Go ahead.
Good. I don't think that works. I mean, I think it's pretty well understood among direct primary care doctors that the monthly fee itself is not a reimbursable item, and therefore I wouldn't encourage patients in my primary care practice to file for the monthly fee.
Right.
So I talked a few months ago. I talked to Phil Eskew, who with DBC Frontier,
Right.
and he said about half of DPC practices do provide a visit code, like a billing code, maybe on at the request of the patient, or maybe just as a course of their doing business. But it's my understanding that, if you've collected fees, let's say it's a monthly subscription fee, and then you provide a service, then you could create a bill for the service that you provided and take it out of whatever monthly fees were paid to create a proper billing document that could be reimbursed.
Yeah, I think it's a gray area, and there's some. I'm not saying obviously I'm not a specialist in this. It requires sort of legal guidance and so forth. But I think if there are the direct primary care doctors listening, I think they need to be aware that there's some difficulty and potential liabilities. If on the one hand they provide a service that seems to be fully all comprehensive, on the other hand they claim that they submit a bill for something else. I don't know. I think I'd be if I were a doctor, I'd be cautious and about how to do this. I think it's easier.
But essentially,
there are services that are clearly not included in the monthly fee.
Right.
Services that are clearly not included in the monthly fee and that have some kind of CPT code associated with them, then there's no problem there.
Sure.
Yeah.
Right. So I guess our target market is sort of the out-of-network practices that are not doing the monthly subscription model.
Right.
I personally know a DPC doctor who does do the sort of what I just outlined, which is collect a monthly fee, but then if a patient needs an amount and a code associated with it, we'll create one for a particular interaction. But you're right that this varies. Different states have different rules on this process, and certainly people need to seek guidance. But like I said, I spoke with Phil Eskew, who's an MD and a JD, and he was very interested in it as potentially applicable to many DPC practices, maybe not all, but many of them.
Did you find that over time it seems like the out-of-network coverage has really evolved in terms of what the insurance companies are doing, correct? So it seemed to be that there used to be a certain percentage of costs that the out-of-network would be covered. So 80% or something like that if you went out-of-network, and leave that 20% with the patient. Over time, have you found that, or at least it seems that a lot have evolved to be to involve just a deductible, like a high deductible, right? So it's some $5,000-$6,000 deductible for out-of-network before the insurance company even starts to pick up anything. I think this is what when we talked to Keith Smith from the Surgery Center of Oklahoma, what he was talking about when he was referring to the fact that he used to get a ton of out-of-network patients that would flock to him because even their 20% of what they had to pay was still less than what their in-network deductible was. Then the insurance company sort of got wise to that and then amped up the deductible for the out-of-network folks as well. Are you finding so then then it you end up filing all these claims, but it's like, oh look, you still end up paying the whole amount because it's you're not meeting your deductible. Are you finding that, or?
It's certainly a challenge, and yes, Keith Smith certainly has been in this world much longer than I have, with my practice and with Reimbursify. But I think there's two responses I have to that. I think what Dr. Smith had talked about was partly that his state, his local insurers ramped up their deductibles just to steer patients away from his practice, right. Which is an interesting case study in business and politics. But there's many people's deductibles have gone up, both in network and out of network. So it is a constant challenge. On the flip side, 60 or 70% of private insurance in this country is funded through self-insured groups. And many of those self-insured groups still offer a decent, healthy benefit with low-ish deductibles compared to the 5,000, 8,000 level that we're discussing. So we don't have comparative data because 2018 is the first year we've been doing business as Reimbursify, but there's still a healthy contingent out there who are seeking reimbursement and getting it, through their insurance plan.
I know, at least it's been my observation that for many patients, even if they don't get anything back, they like to file. They like to submit something. First of all, it does count towards the deductible. So, they never know if later in the year they're going to meet that deductible or not. But number two, they get a sense of satisfaction that, they're getting, they've been paying thousands of dollars for their health plan, every month. And they feel that they're, at least the least they can do is file a claim and make it count towards something, even if they don't get much.
It's like standing up for something, against your insurance.
Right. I have many patients who are, who are comfortable with the expectation that they're not going to get anything back, but they still go through the motion of filing the claim.
So this does exclude Medicare patients, correct? Meaning Medicare has no out-of-network benefit, right?
Correct.
Medicaid has no out-of-network benefit, right?
Correct.
So Medicare, Medicaid
so we
so this
estimate,
primarily commercial insurers, yeah.
Right. Yeah, we estimate about 100 million plus or minus folks in the country with private health insurance.
So Medicare for all would not be good for Reimbursify.
Medicare for all would be maybe not good for a lot of things.
Sorry.
Go ahead, Anish.
I was curious. I was hoping to hear about how you got to where you are. Did you start out in private practice, or?
So I trained at Vanderbilt, and then I was on faculty at Vanderbilt and in networked all their plans and did some private practice and did some teaching there. And then moved to New York City, got engaged, moved to New York City, and then realized that my academic job didn't really pay my rent in New York City. And so I had to come up with another option. And I was pleasantly surprised to see that the private practice landscape in Manhattan was was thriving, and was a lot of direct pay out of network practices of all stripes, not just my specialty. And I've always, even before I came to New York, it was always something that just felt more pure in terms of a practice modality to me. And so, it's something that I aligned with. And so that's when I first started. That's back in 2006, 2007 that I started my first practice, which I actually sold my New York practice before working on Reimbursify.
I see. Manhattan is a super interesting place. I mean, there's so many ZocDoc emerged from there. It really seems to be a font of innovation in terms of healthcare service delivery, if you will. And it seems like the reason, the reasons for it is, of course, it's just a massive metropolis. There's a young, very tech savvy population that are open to opening a doc on ZocDoc or using Reimbursify or paying directly. But any other any other reasons you found in terms of why it is that Manhattan, private practice thrives, and specifically direct pay out of network, thrives so well in Manhattan?
I think it's partly, Manhattan's the type of place where you can make, you can kind of get anything you want, anytime you want for, if you can pay the price for it. So there's a little bit of that. And I think coming from another region to Manhattan, I think one of the calculations is in many parts of the country, you can make a very comfortable living being in network. You obviously put up with other detrimental things perhaps, but from a fee for service perspective in network, you would, it's a heavier lift, right? Than to say, oh, well, why would I, when I was in Nashville, Tennessee, it's a heavier lift to say, well, why would I ditch insurance? I'm comfortable. My patients are comfortable. We kind of are not focused on the third-party payer issues, or at least we don't see them, so we're not focused on them. And so I think that's one of the reasons that out-of-network practices seem to be more prominent in bigger metro areas, where the cost of living might be higher. And so a different economic model needs to apply, and it kind of forces people to do that. My daughter sees a pulmonologist for asthma, and a year and a half ago, and he's in Westchester, north of New York City. And a year and a half ago, we got a letter saying he's dropping out of all insurance plans. So I think we're seeing that in a lot of places, and even my friends back in Nashville, many of them are there seems to be a movement towards more of a direct pay style practice, but I think that's why the big metro areas are kind of leading it.
Yeah, and that's what I was leading up to was the fact that I feel like the chicken who is constantly complaining about the sky is about to fall, right? Is that the right parable? And it's we seem to be headed towards a place where third-party payments are becoming more and more and more onerous, and we kind of all think of it collectively. Those of us who are still enjoying third-party payment for what it's worth, we kind of think of that'll be the end times when that happens. But Manhattan kind of gives you, Manhattan is, of course, I don't know how many years advanced from everyone else. So when it comes to a time where third-party payment, and it's already happened in Manhattan, isn't enough to give physicians whatever status or whatever stuff it is that they want, or it seems like naturally the model that you're talking about will emerge. So perhaps Manhattan represents the future for all of us.
Sounds good. That's all. Yeah. What's the next step for you? Just you're launching. You want the words to spread from doctor to doctor, and is there going to be an add-on to the app, or that's essentially the product that you see?
So
sort of stable. Yeah.
Yeah. So we just want more and more users. We want to kind of own the out-of-network reimbursement space on the patient side. And if we can help move the needle towards a little more free market in medicine, that's also kind of a good side effect for us. But we are working on some other products. For example, we're beta testing right now a little plugin that people can put right on their website. So a doctor can just say, file your claims from my website. So that's going to be exciting. We are, some practices we've encountered actually do some billing. They might, even though they're out of network and the patient pays them directly, they actually have staff that does the claim filing. And so we want to have sort of an expanded professional version of our system for those types of offices to use. Right. And yeah, that's about it. Our next goal is 10,000 users, and then maybe I'll come back and talk about it again then.
Sounds
Wonderful.
great. Always happy to hear about innovation like this that again can help the free markets make tiny but significant inroads in the system here. Very good, Vatsal. Thank you very much for joining us.
Thanks.
Okay, thank you.